Okay, as already alluded to, there are two main domains of symptoms and manifestations in systemic mastocytosis. One is related to the release of mediators for mast cell, and as underlined by Andreas, this is more typical of indolent systemic mastocytosis rather than aggressive systemic mastocytosis. However, some patients may still have these kind of symptoms, and so there are a number of therapeutical approaches that can be used to that end. And I have to say that even if anaphylaxis is quite rare in advanced systemic mastocytosis, we have all our patients with epinephrine self-injections to have at home and to take with themselves when they are out. Involvement of the bone is typical of advanced systemic mastocytosis as osteosclerosis. Again, Andreas made the right job. However, we have patients, especially young male patients, who have osteoporosis, and this may occur prevalently in indolent, but sometimes also in advanced systemic mastocytosis. So there are different subtypes of systemic mastocytosis, advanced systemic mastocytosis, and how do we use the approach in terms of treatment for these 4 different subtypes, actually 3 different, but there's a 4th one that they have added, we'll see as the latest one. So in case of advanced systemic mastocytosis, the preferred therapeutic options are represented by KIT inhibitors, avapritinib, and midostaurin, but do not forget that these patients should be also referred to centers, specialized centers, because this is a rare disease, and so these specialized centers may have also the availability of clinical trials, and whenever possible, patients should be enrolled in clinical trials. Other therapeutic options, Johannes already mentioned that, are cladribine, but also interferon, and some patients received, often in combination, prednisone. For some of these patients, if they do not respond, if they relapse from an initial response, of course, the second-line treatment should be kept into account, but also some patients are likely to be referred to stem cell transplantation. In case of advanced systemic mastocytosis with an associated hematological neoplasms, of course, treatment is related to what one thinks is the most relevant of the 2 components of the disease, if this is mainly mastocyte-derived manifestations or rather the additional hematological component. So, of course, again, KIT inhibitors and cytoreduction can be used when the mastocytosis manifestations are most relevant. And in case of the associated hematological neoplasm, of course, these can vary according to the subtype. CMML may be treated, of course, different from another myeloproliferative neoplasm. Most of these patients are actually candidates for stem cell transplantation. We saw a very nice clinical case presented by Andreas that just underlined the difficulty in effectively managing these patients. Mast cell leukemia is the worst of the advanced systemic mastocytosis subtypes. It really had, before the KIT era, a very short survival. So most of these patients, whenever possible, had to be moved to stem cell transplantation. Very few actually were able to go to stem cell transplantation because the disease is very aggressive. Now we have KIT inhibitors that have changed the therapeutic landscape of mast cell leukemia. And again, clinical trials are really something that we should pursue for most of our patients. And some of these cases also are strictly associated with acute myeloid leukemia. So here it's really, the job is really difficult depending on what kind of treatment you use. The 4th, this is not formally recognized, but we added this just to underline the fact that there are cases of advanced systemic mastocytosis who are negative for the KIT D816V mutation. Well, I think that the number of these cases is not really known. It largely depends also on the type of molecular test that you use. NGS is, of course, a fine test, but sometimes if the component is quite low, NGS may turn out to be negative in routine practice. We also have PCR, digital PCR, that is quite sensitive. But some cases are really negative for the D816V mutation. This can be appreciated by using NGS that discovers additional mutations in the KIT. And in these cases, we can try imatinib. Imatinib may be effective in several of these cases. However, there are mutations that are known, for example, the V559IA, that are not imatinib sensitive. Okay, what kind of agents we have? We already mentioned all of them, just a quick run-off through these. Interferon alpha has been used in the past in most of the patients with advanced systemic mastocytosis who were symptomatic. It may be particularly active in case of skeletal or of bone involvement, and often it is combined with the prednisone. Of course, it has all the toxicities and side effects of interferon, and patients who respond, however, have short duration of responses. Cladribine is not approved, as already mentioned. However, it has been largely used in clinical practice. It is still used, especially when you have the need of quite rapid debulking of the disease. It can be delivered in different forms, shorter or longer treatment schedule. Of course, it has toxicities mainly represented by myelosuppressions, lymphopenia, and particularly infections. Up to 70% of patients have been reported to have a response to cladribine. However, again, these are quite short-lived. And what is the main topic of discussion nowadays for systemic mastocytosis is, of course, the availability of KIT inhibitors. We have now 3 different molecules, including, of course, imatinib for selected KIT negative cases, and the bezuclastinib, that is a new molecule in clinical trials, in clinical development. These are drugs that have activity against the D816V mutations. However, they have different inhibitor profile. Midostaurin is a multi-target inhibitor, while avapritinib has higher selectivity against KIT mutation. Okay, what is the clinical evidence based on which these drugs have been approved for treatment in advanced systemic mastocytosis? Jason Goplet, who is in the audience, published in 2016 the results of the first trial with these inhibitors, midostaurin, and he reported very high levels of response, and with an overall response of 60%. And what was really notable in that study was the proportion of patients with mast cell leukemia who had a response. There might be differences in terms of response in different subgroups of patients. For example, patients who have the mutations, the so-called SAR mutations that have been discovered by my friend Andreas Reiter, may be less sensitive to midostaurin as compared to patients who do not have these mutations. But it was also of relevance to show that there are variables that, when changed under treatment, are associated with survival. And these include, of course, reduction of tryptase of alkaline phosphatase, and the extent of response according to different criteria. What is important in these studies is also the fact that there was a clear evidence that when KIT variant allele frequency reduces, here the level was less or more than 25%, this was clearly associated with survival. So this is an evidence of disease-directed activity of midostaurin. Avapritinib is the second KIT inhibitor to be approved in advanced systemic mastocytosis. Again, here we have overall response rate in excess of 70% if you consider the whole population, but it's also of interest for clinical practice to see that naive patients, treatment-naive patients, have higher levels of response, almost close to 90% of the patients. And again, there is a significant rate of response in terms of patients with mast cell leukemia. So if we consider the overall response evaluable populations, these data are from the pivotal phase 2 Pathfinder study and show the 4-year follow-up. This means that response is durable, and this is one of the first key message that we have to take home with avapritinib. But if you consider the treatment-naive population, well, overall survival has not yet been reached after 4 years of treatment. Again, we have quite clear evidence of an activity against the main markers of disease, and these are represented by changes in the frequency of bone marrow mast cells, the level of tryptase, the variant allele frequency of the KIT, and for patients who have splenomegaly before treatment, also the reduction in the spleen volume. There's no head-to-head comparison trial of midostaurin and avapritinib. I fear it will never be done, but to get an idea of the two drugs, Andreas performed this, I'd say, complex statistical analysis that is called inverse probability of treatment weighting, that allowed him to compare the cohort of patients treated with avapritinib in both Explorer and Pathfinder trial with a group of patients in the German registry, if I'm not wrong, who were treated with midostaurin and or cladribine. And you can appreciate from the Kaplan-Meier curves how patients receiving avapritinib did better as compared to both midostaurin and cladribine. And in terms of other ratio of survival, the comparison of avapritinib with midostaurin had another ratio of 0.59 and cladribine 0.32. So clearly an advantage of treating with avapritinib as compared to other established and used lines of therapy. And the duration was again speaking in favor of avapritinib as compared to midostaurin and cladribine. John has already alluded to the importance, to the relevance of targeting, of having in our mind that also improving symptoms, not only reducing mast cell burden or tryptase level, but improving symptoms of patients is a measured goal of treatment. And again, in both the trials of midostaurin and avapritinib, we have clear evidence that treatment impacted in a significant way in reduces the symptoms and improving the quality of life of the patient. So this is an important objective of treatment for a chronic disease that now is becoming chronic also because responses to avapritinib are long-lived. So this is the current state of the art, but we are looking ahead. There are clinical trials, and among the different molecules that are under clinical development, and I think that Deepti will touch this aspect later on. Bezuclastinib is a highly selective and potent KIT inhibitor that is being explored in a phase 2 trial, the APEX trial. Here are, on your right, the reported data from the primary analysis, and you can see that the data are suggestive of significant activity of the disease, 80% when you use the pure pathological response criteria, and again evidence that almost 90% of the patients has significant and clinically meaningful reduction in terms of serum tryptase levels, the number and the aggregates of bone marrow mast cells, and reduction on the variant allele frequency of KIT. The drug is well tolerated. and there is no evidence of bleeding in the central nervous system. That was one of the side effects reported with the first patients treated with avapritinib. This is one of the reasons why in one of the questions there was what was the optimal level to use for allowing a patient to be treated with avapritinib. Bezuclastinib has very limited penetration in the central nervous system, and so this is an advantage of the drug, likely as compared to the previous one. So these are my key takeaways, and again, I will leave as they are. So the main message is that we have different drugs historical drugs for treating advanced systemic mastocytosis. Clearly, whenever possible, now we have KIT inhibitors that have significantly made the change in the history of treatment and likely in the history of disease course in advanced systemic mastocytosis.